Today is the first of hopefully many more, kicking off our HDSA Summer Education Series. My name is Teresa Spellman. I'm the president of the HDSA Greater New York City chapter. And we are a volunteer group who are here to support our local community. So come check us out on Facebook, Twitter, and Instagram. And typically, we do this in collaboration with Columbia as an in-person, but obviously this year has thrown us for quite a loop. So we had to shift pretty quickly and really excited to bring this to the broader community, which is one of the actual upsides of the situation, that we can share it out widely. So thank you for joining. And just, over the course of the summer, so you're all aware, we are going to have more of these through the collaboration with Columbia University, HDSA Center of Excellence in New York City. Just want to say that we encourage everyone to, ask questions via the anonymous chat function. And we'll try to do our best to answer those either throughout the presentation or towards the end, depending on how time goes. And for the presentation today, just want to mention a few things about the HDSA Center of Excellence at Columbia. They would like you to know that, they're open for telehealth visits for support, an appointment on most Fridays, and in person for new patients, actually sometime in July. And the contact information actually will be included. There's a phone number on the last page of the presentation. And also wanted to let you know that the Center of Excellence is also now open for clinical trial visits on site, and they're actively enrolling in the study that is going to be discussed today with Dr. Huey, the NAP study. We hope to be able to offer the enroll observational visits on site also in the near future. And as part of the education series, we're going to plan to provide an update on the status of research studies throughout the beginning of each session. But if you have any questions, I'll throw a phone number out there and contact info, which, if you miss it, happy to repeat that later, but it would be to reach out to Paula Wasserman at 212-305-4597. Now, I just want to, introduce our terrific speaker today. So we've got Dr. Huey with us, who's the neuropsychiatrist for the HDSA Center of Excellence at Columbia University. He is an associate professor of psychiatry and neurology at Columbia University Medical Center, and he received his BA degree from Yale, his MD degree from Stanford, and completed a fellowship at the NINDS in Bethesda. He joined the Columbia faculty in 2010 and has been part of the Center of Excellence interdisciplinary team since 2014. His research work focuses on psychiatric symptoms such as depression, irritability, and impulsivity that occur in diseases such as Huntington's disease, frontotemporal dementia, and Alzheimer's disease as well. And his ultimate goal, which I'm sure he'll tell you about shortly, is to develop better treatment for these symptoms. And Dr. Huey is equally active in the providing of clinical care and developing innovative research, which is quite rare. He is truly one of those rare doctors that never loses sight of the patients that he is treating. His awards and his grants are too lengthy for the length of the webinar that we've got today. But I just want to mention that he recently obtained tenure at Columbia University. And also, I'm quite jealous of this, he recently adopted a poodle for, for his family. Don't know if you knew we were telling everybody that, after much needling from his kids. And so I just want to say thank you on behalf of the HDSA team here, the New York chapter and Columbia Center of Excellence, to being our first presenter of the summer series and this really important topic of neuropsychiatric symptoms and Huntington's disease and the NAPS study. So now I'll turn it over to you.
Thank you so much for that kind introduction. And I'm very impressed at your information sources, about the poodle especially. That's very impressive. But no, that's a very, very kind introduction, and thank you. And I am really very grateful to the HDSA and to Teresa for inviting me. It's a wonderful organization. You know, all of my contacts with the HDSA is, you know, they've done such amazing work, and so it's an honor and privilege to speak to you all, and I really appreciate being invited. So as you heard, I am a psychiatrist, and often when people, you know, ask me what I do and what patients I see, and when I say, you know, Huntington's disease patients among them, almost always the first question I get is, but isn't that a neurological disorder and you're a psychiatrist? The answer to which is, you know, it is a neurological disorder, but with frequent psychiatric symptoms and complications, which is my main role in the clinic and with this disorder. Next slide, please. So when I was in medical school, you know, we learned that neurodegenerative disorders were mostly just one symptom. So you had disorders such as Alzheimer's disease, which were cognitive disorders, and then you had disorders like Parkinson's disease and Huntington's disease, which were motor disorders. We now know that really most, if not all, neurodegenerative disorders can have different types of symptoms, and the proportion differs and the types of symptoms differ. But I think the way I think about neurodegenerative disorder symptoms are as a three-legged stool, where one leg of the stool is motor symptoms, one leg is cognitive symptoms, and the other leg, you can call it, here I've listed it, so it's NPS, standing for neuropsychiatric symptoms. Another term, which I kind of like in some ways almost better, because it's a little broader, is behavioral and psychiatric symptoms, or non-motor, non-cognitive symptoms. So those are symptoms, either emotional, behavioral changes that don't fit into either motor or cognitive symptoms. And almost like most neurodegenerative disorders will have a mix of these three legs of the stool. Huntington's disease, I think especially, really kind of people can have symptoms in all three of these domains, and often all of them at the same time. Next slide, please. Just as an aside, you know, feel free, I have my eye on the chat window if questions come up. Happy to talk about it during the presentation, and after as well is great too. So this is a slide from a nice paper where they were just looking at the prevalence of different psychiatric symptoms in Huntington's disease as the disease, over different stages as the disease progressed. And so you can see on the one axis, the vertical axis is prevalence, and then they have on the other axis different neuropsychiatric symptoms, and then the different disease stages on the third axis in a three-dimensional graph. And in the far back in the kind of blue-green is apathy, and then the next one in the green is obsessive compulsive behaviors. In the yellow is irritability and aggression. In the orange is depression, and then psychosis is in the red. So you can see that these symptoms are quite common, and they usually will become more common over the course of the illness. This is just looking at moderate to severe symptoms. So if you see that the prevalence of apathy by the end of the disorder is up to 50%, and that's moderate to severe. If you include mild for all these symptoms, that prevalence goes up, or the vast majority of people will have some what we would call non-motor, non-cognitive, or neuropsychiatric symptoms. This graph also gives you a little bit of a sense of what those symptoms are. That the symptoms of HD vary between neuropsychiatric symptoms between individuals, but we hear the same themes, similar themes or similar symptoms over and over again. Often a lot of obsessionality, so getting very fixed on a topic and having trouble moving on, getting very focused on a topic or on an idea. irritability and lability, so people kind of flying off the handle or having much more of a temper. Depression and anxiety, so feeling down, feeling anxious, although the flying off the handle can occur in the absence of that depression or anxiety as well. So sometimes people are doing fine, but they just have a very short trigger. Psychosis is quite rare, but can occur in Huntington's disease. And by psychosis, the definition of that is either hallucinations and or delusions, false beliefs. So people believe things that aren't true, or they're seeing or hearing things. And that's rare, but can occur. The other ones, so the apathy, obsessionality, irritability, depression, anxiety are really the much more common symptoms, neuropsychiatric symptoms of HD. Next slide, please. This slide's a little complicated, but and I think it makes an important point. So let me walk you through it. So this is the question of, well, when do these symptoms develop in patients with HD? And we're getting evidence that these symptoms are often early neuropsychiatric symptoms, and often can even be the earliest symptoms of HD. So what this is a study where they took people with the mutation that causes Huntington's disease and family members who didn't have it, and they put them into 4 categories, and these are the 4 columns you see in each of these little boxes here. And the categories, that's where it says control, those are people who didn't have the mutation, so they're not going to get Huntington's disease. And then low, medium, and high means people who are, because of their CAG repeat length, which you probably know is an aspect of the mutation that is associated with the age of onset of the illness, of when if they were of low, medium, or high probability to develop motor symptoms in the next 5 years. So remember, none of these people have any chorea, any motor symptoms. They're all what we would call pre-manifest, so pre-motor symptoms in Huntington's disease. And then what they did is they assessed them at baseline and they followed them. And the orange line is if you ask an informant how they're doing or about a symptom, and the green line is if you ask the participant themselves. And then each box represents a different symptom, psychiatric symptom. So you can see obsessive compulsive, you can see depression, anxiety. And what you can see is that the people who have the mutation that causes Huntington's disease, even before they develop the motor symptoms, so this is often several years before developing the motor symptoms, we'll have increased prevalence of depression, anxiety, obsessive compulsive symptoms, and then they go up kind of as they approach the motor symptom, the age where they're developing the motor symptoms. So depending on whether they're at low, medium, or high probability of developing those motor symptoms. And we see this clinically a fair amount, where a patient will come in and will have motor symptoms, we'll diagnose them, but as part of the history, they say, well, the child will say, well, mom, actually has been irritable for a couple of years now, and really flying off the handle. So psychiatric symptoms can be quite early in the course of the illness. Next slide, please. This slide is also saying that these symptoms, the neuropsychiatric symptoms, can also have a big impact on quality of life. So this was a study where they looked at quality of life in patients with Huntington's disease, and they were looking at pre-manifest and early manifest. So what that means is people before motor symptoms or with very early motor symptoms. And they found that in these patients, that the neuropsychiatric symptoms and the cognitive, in this case executive dysfunction, which is a type of cognitive problem, really had the greatest quality of life effects in people with Huntington's disease. That when you talk to them and their partners, these were the symptoms that were really interfering with getting done the things they wanted to get done. Next slide, please. So, you would say, the one thing that is kind of, well, there are many things, but one aspect that's gratifying about treating these symptoms in the clinic is that we actually can do more for these non-motor, non-cognitive symptoms or neuropsychiatric symptoms than we can for the motor or the cognitive symptoms. We really don't have great treatments for the cognitive symptoms, The motor symptoms you'll hear more about in some subsequent talks. We obviously have non-pharmacologic treatments and occasionally pharmacologic treatments, but the neuropsychiatric symptoms, depending on the symptom and depending when they occur in the course of the illness, can respond well to medication treatment. So in an ideal world, we would have lots of trials where we had tried different things and we had determined what works better for which particular symptoms, and we're not there. So there have been very few trials done of treatment of psychiatric symptoms in Huntington's disease, and that's one of the reasons I'm interested in this in my research. So what this author did, Karen Anderson, who was trained by Dr. Karen Marder, who a lot of you know heads our clinic, the neurologist who heads our clinic. She's also a psychiatrist who trained at Columbia and then went on. And what she did in these studies, and for the next couple of slides I'm going to show you, is a necessary first step before we really kind of have all of the evidence and the good studies comparing different medication and other treatments for neuropsychiatric symptoms, which is they asked a bunch of psychiatrists and neurologists who are treating these symptoms in these patients, and they said, what are you doing? How are you treating these symptoms? And came up with sort of consensus recommendations of what people were doing. Now, as you can see, they've split it into non-pharmacological and pharmacological, and it's very important not to forget the non-pharmacological aspects of treatment. Those are very important for these. And then they split it into different symptoms. The next couple slides, I'll kind of go over what the kind of expert consensus recommendations were about this. So first, in agitation and the non-pharmacologic factors of reducing excessive noise or stimulation, giving people time to calm down and to get out of a situation that might be triggering anxiety, giving verbal support and emotional support for these patients, making sure that there's nothing else that might be causing the agitation, a medical problem. And then down to the bottom, talking about pharmacologic recommendations, with the preferred initial agent being what we call an antipsychotic medication. Now, one thing you'll see both in what we call these symptoms and the medications is most of them are borrowed from psychiatry, and some of the terms really aren't appropriate anymore, don't hold, but we use them because they're historical. So these antipsychotic medications, most of the people who are using them aren't psychotic. If you remember, I told you before, psychosis is having delusions or hallucinations, but they have been shown to have some efficacy against agitation, aggression, and so we use them, again, even in people who aren't psychotic. But that's usually one of our first-line pharmacologic agents for the treatment of agitation in HD. Next slide, please. Anxiety, this is from the same paper. One thing I would like to highlight in the non-pharmacologic recommendations is that, and again, this is largely borrowing from the psychiatry world, but psychotherapy can be really efficacious against anxiety and obsessionality, which is often a problem in people with Huntington's disease. And so it's something we shouldn't ignore or forget, that in non-neurologic populations, psychotherapy for anxiety works just about as well as the drugs, and they work best together. So, and usually when we refer people for psychotherapy who have Huntington's disease for anxiety, obsessionality, we usually refer for what we would call more directed psychotherapy. So, a lot of people have the idea psychotherapy is lying on the couch and talking about your childhood. But that's kind of the old school psychotherapy. What psychotherapy is now, a lot of it is more symptom oriented and learning specific techniques to reduce and manage symptoms. So they're usually short course, they're focused on whatever the problem is. It'll be a course of 10 sessions or something. And they can be quite helpful for this. And so it is something to consider for all loved ones with Huntington's disease. It can be hard to get in terms of insurance and things like that, but it can be very useful. In terms of pharmacologic recommendations, you can see in the slide here, SSRI, which stands for selective serotonin reuptake inhibitor antidepressant, is the first-line agent. There appears to be a role of the neurotransmitter serotonin in both anxiety and obsessionality, and these medications that increase the amount of serotonin available to the brain can help with both of those. And again, to borrow from psychiatry, these are medications we use for other psychiatric disorders which have a lot of obsessionality, like obsessive compulsive disorder. Now, again, it's a misnomer because these are called antidepressants, but they really are, we're using them for anxiety, and we use them frequently in patients who are not depressed. Next slide, please. So apathy, we talked about as being, can be an important symptom in Huntington's disease, but in other neurodegenerative diseases as well. And, you know, often people will call it the common cold of neuropsychiatry, in the sense that it's a common symptom of many neurodegenerative diseases that affect the brain. And it is hard, we don't have good pharmacologic treatments for it. So, you know, usually we focus on the non-pharmacologic treatments for apathy. So structured activities, usually like one of the characteristics of apathy, and one of the things that as clinicians we're trying to evaluate and distinguish when we see people with apathy. So apathy just means not as motivated to do things. We separate it out from depression, where depression is people don't want to do things, but they're feeling actively sad, they're feeling bad. People with apathy don't feel actively sad, and they usually, if you take them and they go to an activity, they usually will have an okay time. And so what we will usually recommend for the loved one, the family members and loved ones of patients with apathy is to basically kind of be more directive in their scheduling and in their day, such that you take them out to a family gathering instead, whereas before maybe they organized it and they set it up. Now someone else will have to do it, but they still will have an okay time if they go. And so we encourage people to kind of facilitate that for people with this symptom. Pharmacologically, it really doesn't respond very much to medications, and some of the medications that we try in other disorders can worsen the motor symptoms of Huntington's disease. So usually we rely with apathy much more on the kind of non-pharmacologic treatments. Next slide, please. And then psychosis, which, as I said, is rare. About 5% of people with HD will develop this symptom. Obviously, it can be a real problem, but again, it's rare in HD. And usually, when we see it in HD, it does have a, it has a kind of, it has a HD flavor to it, in the sense that often it'll have a large obsessionality, anxiety component, where people are getting very, very obsessed over something to the point where they kind of start to lose touch with reality. Luckily, quite rare in HD, and we often will use an antipsychotic medication. Next slide, please. And then sleep disorders are common, with insomnia being a big problem. It often, in my experience, is linked to the anxiety and obsessionality, in the sense that I'll often hear from patients that they're lying in bed worrying about things they have to do maybe the next day, or chores and activities they have to do, and they have trouble turning it off to get to sleep. So often the treatment for insomnia is to treat the anxiety and the other psychiatric symptoms, but we also will treat insomnia as well. Always our first step is, as you can see here, what we call sleep hygiene. So making sure people are getting to bed at a good hour, that the bedroom is used primarily for sleep, that it's a dark, quiet space, all of the things, the behaviors around sleep that contribute to good sleep, which we call sleep hygiene. We can provide pharmacologic assistance. We often start with something mild like a melatonin, and then can go to different medications, sometimes using what we call a benzodiazepine, such as Klonopin, to help with sleep as well. But sleep can be quite disrupted in Huntington's disease. Next slide, please. So I think you can tell from, I'm getting into a little more of the research now. I think you can tell from the data I've been, the slides I've been presenting so far that we're borrowing a lot in not just Huntington's disease, but all neurodegenerative disorders, the neuropsychiatric side of it, where both the terminology, the treatments, the disease definition, the disorder definitions, we're borrowing from psychiatry a lot. And one theme through my research and clinical care is that, you know, that can be a problem. So this slide here is just a cartoon where in black, that MDD stands for major depressive disorder. If you go to the psychiatric manual and look up what psychiatrists say depression is, major depressive disorder, by the rules of that manual, these are the symptoms, those 8 symptoms listed. And you have to have the first one or the second one, and then some of the 3 through 8. Now, that's fine, and that's good to, you know, to define it and be clear about it, but the problem is that these disorders, the psychiatric disorders in the psychiatric manual, were defined in young people without any kind of neurodegenerative problems. And patients with neurodegenerative illness, and here in purple is Huntington's disease, and red is frontotemporal dementia, which is another neurodegenerative disease I work with, and green, Alzheimer's disease. They don't fit this same symptom profile that you know, 20-year-olds who are presenting to Columbia Student Health do. They have their own symptom profiles, and I think one thing you all know, having lived it, oh, sorry, it says audio. I think the audio is working now. You know, we see in the research as well is that patients with Huntington's disease have a specific set of symptoms that they tend to get, and it's not the same as major depressive disorder. So it has some of the symptoms, but not all of it. And each of these different neurodegenerative disorders will have pieces of the major depressive disorder syndrome, but it's really not the same thing. Next slide, please. So what we're trying to do, what we're trying to do with our research is redefining these neuropsychiatric syndromes. So, you know, when I read in a textbook, oh, patients with Huntington's disease, you know, have major depressive disorder, you know, my reaction is not really. You know, they get what they get, which are the symptoms that we see in Huntington's disease, but the clustering is very different between that and, again, someone without a neurodegenerative disorder. So we're doing a study called NAPS, which is Neurodegeneration-Associated Psychiatric Syndromes. And basically, it's this question in the blue box. Can we redefine these syndromes on the basis of the anatomy affected and the neurodegeneration, you know, the areas that are being targeted by the neurodegeneration? So we are enrolling a large number, 600 patients with all different kinds of neurodegenerative illnesses. And we ask a lot of psychiatric symptom questions. We're now with COVID, we are switched over to a purely remote format for the gathering of the symptoms. And then when things open up from COVID, we will do an MRI scan, and then we will make associations between what we see on the MRI scan and what people are presenting. But for right now, we're doing just the psychiatric assessment. And it's really doesn't take that long. I did one actually today. It takes maybe an hour to 2 hours on the Zoom, on the video. We are very happy to have more participants. As you can see, our numbers are very large. That was one of the, when we did the math of how many subjects we would need to really kind of prove what we want to do scientifically, it was quite large, but we're still hoping to make our target. So we would love anybody who's interested in this. And again, we can do over Zoom with a later MRI. And if you're bored at home because of having to be social distance because of COVID, and we will give a $50 Amazon gift certificate as well for doing the evaluation, and then another $50 for the MRI. Could you go to the next slide, please? And then we have another grant project which we're undertaking called PAVES, Positive and Negative Valence Emotional Systems in Neurodegenerative Disease. We're going to start back up once things open up a little more from COVID, because that involves having to interact with people. But the idea behind that is that the psychiatric symptoms that we're observing in Huntington's disease and other disorders, are linked to more basic systems in the brain. And so we're probing and investigating those systems in the brain in patients that we're also getting the psychiatric data from NAPS. So we're doing kind of more basic paradigms of how does blood pressure change, how does threat response change, and things like that. You can see here on the left, these are the more basic systems that are associated with emotion regulation to try to figure out where are the problems and what's the neuroanatomy. Now, the goal of that in the long run is to understand this better, to develop better pharmacologic treatments, but also to make the jump to anatomically based treatments where we might be able to correct some of the problems in these systems on an anatomic level and thus relieve people of these symptoms. Next slide, please. So this is contact information if you're interested in even just finding out more about the research or in participating or anything. This email is Huey Research Team. So my name, the research team at CUMC, stands for Columbia University Medical Center.columbia.edu, and then the phone numbers below. And we are happy to hear from everyone. And most people I think have done it, find it kind of interesting. So we're happy also to talk about the science of it and what we're looking for as well too. And I think, do you have a slide about the next the talks? Or is that the end? Oh, and upcoming talks, which, well, I'll tell you briefly, but Dr. Shah, who's who's a neurologist in the clinic, talking about the very exciting Change HD study. And then Lori Quinn, who is a physical therapist, talking about very important exercise at home strategies. So thank you very much.